Hi, I'm Carrie Konoski, bringing you kidney cancer news from the 16th International Symposium on Palliative Medicine and Supportive Oncology. This 2.5-day CME-certified event brings together the leading physicians and healthcare professionals in this field. And now Bill Breaux has some more news that of interest for patients and their families dealing with kidney cancer.
Thanks, Carrie. In just a few moments, we'll visit the European International Kidney Cancer Symposium. But first, from MedWire News, reporter Lucy Piper reports researchers have identified mutation-defined subtypes of clear cell renal cell carcinoma that have distinct clinical outcomes. They found that patients with CRCC positive for BAP1 gene mutations presented with more aggressive tumors and had significantly worse overall survival than patients with clear cell renal cell carcinoma positive for PBRM1 mutations. The median overall survival was significantly shorter in patients with BAP1 mutations at 4.6 years versus 10.6 years for patients with the other mutation. Discussing the findings, Tony Schwery and colleagues from Harvard Medical School in Boston say, although the clinical utility of these mutations' status as biomarkers for renal cell carcinoma might not be immediately applicable in daily clinical practice, these findings are a meaningful step. And in other news, chemists at University of California, Riverside have developed a compound that holds promise in the laboratory in fighting renal cancers. Named TIR-199, it targets a cellular complex in kidney cancer cells in a manner that's similar to an FDA-approved multiple myeloma drug. Michael Purung, a distinguished professor of chemistry at UC Riverside, announced the development of TIR-199 in a lecture he gave recently at the 5th International Conference on Drug Discovery and Therapy, held in Dubai. Operating like the garbage dump of a cell, it breaks down proteins. He says the novel feature is that it is selective in inhibiting the growth of only renal cancer cell lines. The project was funded by a grant to Tanya Ibarra Rivera, a former postdoctoral researcher after whose initials the compound is named.
Join us again next month for another edition of Kidney Cancer News. I'm Carrie Konoski, wishing you good health.
As you have already heard, renal cell carcinoma, has very high metastatic potential. The rate of solitary metastasis is quite low, doesn't exceed 11%, while the majority of patients have multiple metastases to 3 or more sites. Complete resection of solitary or limited number of multiple metastases can be curative or prolonged survival, and it is well established, and it could be due to combination of patient selection factors and surgical resection itself. Resection of symptomatic lesions may provide effective palliation to such sites as bone and brain and some other sites by relieving pain, preventing fractures, and improving patients' quality of life. In patients with partial response to systemic therapy, resection of residual metastasis might provide a longer disease control. And last but not least, in patients with no evidence of disease after complete resection of all metastases, discontinuation of systemic therapy may reduce its cost and avoid toxicity associated with targeted therapy. One of the largest metastasectomy series from Memorial Sloan Kettering showed that overall survival of 141 patients after curative metastasectomy was significantly better than after non-curative surgery and compared to patients who were treated conservatively. The factors independently predictive of survival in multivariate analysis included disease-free interval, more than 1 year, single-site metastatic foci, and complete metastasectomy. 5-year overall survival of 361 patients who underwent metastasectomy at my institution reached 37%, and female gender, disease-free interval more than 6 months, and again complete metastasectomy were found to be the most significant prognostic factors. But when we looked only at pulmonary metastasis, the only significant factor that influenced overall survival significantly was complete removal of all visible disease. Metastatic renal cell carcinoma of bone is often associated with disabling pain and mechanical failure of skeleton due to pathological fractures. Surgical excision may provide local control, pain relief, and improve function in most of the patients. Most prognostic factors are very similar to those reported in other trials and include solitary metastasis, large disease-free interval, achievement of disease-free status, and in patients with solitary metastasis, surgical excision provides 5-year-old survival which exceeds 50%. Different types of decompressive surgery with stabilization of involved vertebrae may be needed in patients with vertebral metastasis to prevent serious complications and to control local disease. Most orthopedic surgeons advocate the widest excision as technically possible because achievement of free of disease status is the best chance for these patients to become long-term survivors. Patients with brain metastasis are usually highly symptomatic. The prognosis is very poor with median overall survival around 4 to 10 months. It's been shown that the surgery or radiosurgery may provide improvement of survival and symptom relief. Palliative resection of unusual metastatic lesions may be required in some patients to relieve pain, improve function, and for cosmetic reasons, as in this case with large metastatic lesion. Targeted therapy provide better response in metastatic RCC, but complete responses are still rare. The rate of partial responses is much higher, but it's unknown if we have a partial response, what is left? Is it a viable tissue cancer or it's a necrosis? It's been demonstrated by FIRIC that that histologically active Ki67 positive renal cell cancer was present in 82% of resected metastatic specimens. Another retrospective trial which included 22 patients with partial response after targeted therapy and which followed by removal of these residual lesions showed that none of the patients achieved a pathologic complete response. This is just an example, one of my patients who received 21 cycles of TKI followed by removal of, with partial response, followed by removal of these 2 retroperitoneal lesions. And as you can see, histology showed viable clear cell carcinoma with only some areas with partial necrosis. So I may conclude that surgical resection of residual metastasis in patients with partial response to targeted therapy is indicated to achieve complete remission because of biologically active kidney cancer tissue. Another very important issue is whether we can achieve long-term free status by metastasectomy after targeted therapy. A group from MD Anderson retrospectively analyzed 22 patients from 3 centers who received at least 1 cycle of targeted therapy before resection of all visible disease. Surgery was safe, no deaths. 9 patients received targeted therapy post-operatively, and 50% of patients had no recurrence at a median of 43 weeks, which is not bad, and 21 of 22 were alive at a median follow-up of 109 weeks. In view of the fact that targeted therapy generally remains a palliative, long-term, continuous treatment, side effects, toxicity, quality of life, and high cost of the therapy is very important issues. It's unknown whether we can stop targeted therapy after achieving a complete response and re-administer targeted therapy in case of recurrence. 36 patients have been evaluated, patients who, you've already seen this slide, the previous presentation. 36 patients achieved complete response either with targeted therapy alone or with targeted therapy followed by surgical residual metastasectomy. Recurrence was recurrence was seen almost in all patients, in 2/3, 66%, but re-exposure to targeted therapy, what is very important from my point of view, was effective in 87% of cases. Every third patient was recurrent-free at a median of 12 months, and median time of targeted therapy was 7 months. In multivariate analysis, none of the variables potentially predictive of survival was not associated with the time to recurrence or progression, including the type of achieving complete response, whether it was complete response achieved by targeted therapy alone or by combination of targeted therapy with surgery. Another trial, retrospective study of 64 patients, showed almost the same results. About 50% of patients had no recurrence at a median of 322 days after stopping targeted therapy, which is not bad at all. So we can conclude. Complete resection of solitary and limited number of multiple metastases can be curative and prolong survival. Metastasectomy can provide effective palliation for symptomatic metastatic disease to such sites as bone and brain and some other sites. Consolidative metastasectomy is feasible with acceptable morbidity. Significant time of targeted therapy and long-term tumor-free status are possible. And further molecular studies are needed to understand the heterogeneity in biologic behavior of metastatic RCC and the role of surgery in long-term cancer control. Several questions remain unanswered when treating a patient who is a potential candidate for metastasectomy, such as, is targeted therapy needed before metastasectomy? And if yes, what is the initial choice of agent? And what is the optimal treatment duration? Whether we should resume therapy postoperatively or not? And if yes, which the same agent or a new one? In the absence of prospective trials, we can only guess, and our guess is not always the case. Thank you very much.
I have a difficult challenge. I have to convince all the audience, the few who are remainings, no, I'm joking, you are all remainings, on the role of not really radiotherapy, but what we call radiosurgery or stereotactic radiotherapy, and we'll see the differences in a minute for the treatment of metastatic disease in general, but more precisely, of course, for kidney tumors. So we all know the rationale, and we had very nice topic from Dr. Calabro, Dr. Badvev on is there a role for local treatment in the metastatic setting, surgery or something else? And if we do so, when do we do so and how do we do so? So I'm trying once again to convince you that indeed there is something to do with radiation in general and of course with radiosurgery and stereotactic radiotherapy. I'm entering a field which has been very clearly defined by the US, North American colleagues, which is the field of ablative treatment using radiations. That's something you all know in brain. You all know that radiosurgery is a standard treatment for brain metastases, and there is no debate on that. So I could stop right now and say it's a standard. At least it's the standard in brain. And I think you will all agree on that. But of course, the most interesting topic is outside brain. Brain is relatively easy, it doesn't move too much. Outside of brain, it may move, and when it moves, it's an issue for radiotherapy in general and stereotactic radiotherapy in particular. To be clear with you, I have to give you some definitions. I'm sorry about that, but discussing to colleagues outside of the field, sometimes definitions are very important. What we call a stereotactic radiotherapy is the way to deliver very high doses of radiotherapy in very well-defined targets with a precision of a millimeter. So it's a real challenge. But you should know that it is that possible today, even outside of the brain, because the machines which are able to deliver very high doses with a millimeter precision in moving targets do exist, and they do exist around your own settings. So it's possible to fit with that very strict definition and deliver the very precise radiosurgery or stereotactic radiotherapy. Mostly in Europe, we say radiosurgery when we consider a single fraction, and it's typical of brain. Radiosurgery means once only. When we go to stereotactic radiotherapy, in general, we go to 1 to 5 fractions, no more, because otherwise it's fractionated radiotherapy and it's a different word, maybe the word you had yesterday. So we are in this very precise word, a few fractions, very high doses, very precisely defined. Let's see some results outside of the kidney right now, and then we'll enter the renal cell carcinoma. This is data we have published in my own department with something which is considered to be relatively radio-resistant, which is colorectal tumors. And if you look at the results for this colorectal liver metastasis, we very nicely demonstrated in my department that the probability of local control was very high, above 90% at 2 years, if we were able to deliver high dose. When I say high dose, I say 3 times 15 gray. It looks like 45, but by the way, in the biology of radiation, it's not mathematics. This 45 is a physics dose. The biological dose is twice that dose. So be very careful. When we talk on stereotactic radiotherapy or radiosurgery, delivering 45 gray in 3 fractions mean delivering 90 to 100 gray at comparison with classical fractionation. So I can tell you, at that kind of dose, there is no radio-resistant. Not a single tumor is resistant. But we have to be very careful, and we have to very precise define the volume. And I will show you how. So if you look at local recurrence-free survival in this group of more than 150 patients we have very recently published, we demonstrated clearly that the volume was important. Of course, if you deal with big tumors above 5 centimeters in max diameter, it starts to be difficult, but even so, you do control half of these patients. But if you deal with small tumors or relatively small tumors, and if you deliver high dose, even in considered to be radio-resistant tumors, you are very efficient. And even in very radio-resistant tumors, you can be very efficient. This is, of course, palliative treatment, but it's a very big liver metastasis from a primary skin melanoma. And you can see that 51 months later, this patient was quite fine. And he was an 81-year-old patient, something very important too, because, of course, this treatment is non-invasive. It could see it just like a miracle. It's not. But of course, there are difficulties. And the most important difficulty is to rightly select the patient. So I think we had a very nice talk this morning on how to select the low burden, the high burden, the patients with relatively, I would say, latent tumors or the ones with very aggressive tumors. This is totally fitting in my talk. So I'm not going to spend time on that. But what we have here today from, for example, Dr. Calabro, is exactly what is fitting with the use of SBRT, stereotactic body radiotherapy. Let's see some clinical examples. This is coming from my department, a 63-year-old man with a relatively big tumor, metastatic from a renal cell carcinoma. We were 4 months after the initial surgery of the initial primary kidney tumors, and you can see that this patient had quite a big tumors. It was very painful. That's why he was referred to us, because people, the colleagues, the medical oncologist colleague and the urologist were thinking that this was difficult to do surgery on, and this was very painful, so there was no point waiting for some efficacy from targeted therapy. And that's how we did deliver the dose. And once again, you can see that it's very precise delivery. 90 gray, dose equivalent, no critical organs. The lung is very well respected. The only critical organs in such setting could be the ribs. And you have to be very careful, but because, of course, toxicity on the rib is something, but as you can see, the rib was already nicely broken. So that's an issue. 7 centimeters in max diameter. This is a result 26 months later. Okay, this is very classical. If you go back home and if you talk to people around you in radiation oncology departments, we are used to deliver stereotactic radiotherapy with that kind of dose, 3 times 15, with the right equipment and the right definition of the target. This is very classical. Once again, it's classical in brain. It's classical in lung. It's a reference treatment for lung metastasis from colorectal cancer. It's same nowadays in liver. So nothing different. I have just to convince an audience which is not really, I would say, keen with that it's for other topics very, very classical treatment. Just one word on primary, because it's a different issue and I'm not sure that there are many data. I will show you some data to conclude on primary tumor. We have treated in my department a few primary kidney tumors in very specific clinical situations dealing with our urologist colleagues from Professor Arnaud Viller's department. And this is a classical example. I'm not sure there is too much role, except maybe but I would not like to reopen this morning debates on partial nephrectomy, on the role of potential radiosurgery before some kind of surgery. You know, it's standard treatment in oncology in some clinical settings like advanced rectal cancer. Of course, it's a different story. But if you do so, and if you look at the literature, there are a few data presented, that's true. But this is typical of a very nice tumor necrosis you can observe after a relatively low dose of stereotactic radiotherapy. What you see here is the fiducial, that the gold grain we do implant for tracking the tumor, because kidney is moving and you have to track the displacement of the tumor if you want to be very precise. But you can see that is something which is very efficient on a pathological point of view. For you to know, in hepatocarcinoma, we are now starting worldwide, one in US and one in Europe, studies. So hepatocarcinoma is a different topic, but just for you to know, delivering radiosurgery 3x15, stereotactic radiotherapy, before liver transplant, just to wait for the liver transplant. And there is no issue for the surgeons by delivering such a treatment before doing liver transplant for primary hepatocarcinoma. I know it's a different story, but I think there are some issues to talk about. My last slides, I had only 10 minutes. I hope I'll be on time. I will. Some results from lung metastasis from kidney, just kidney, or for primary. My point here will be very classical. If you look at regression and what is the impact of local control, it's once again very depending on the dose, very depending on the dose and the volume. You have to go to that kind of dose once again, 90 to 100 gray, to achieve local control, but you do achieve. So the point is not waiting for too long, otherwise you decrease, of course, local control according to the volume. It's a classical volume effect, but you may deliver very high dose together with a very good tolerance. This was published very recently last year, and that's something you could find coming from the colleagues in Sweden. And that was primary and metastasis recurrence-free survival. The last point is, of course, we are not going to cure everybody by local treatment. And there is a big way to think about combining targeted therapy and local treatments. My conclusion will be exactly the same as from Dr. Matveev. We have a room for combining in a good way, in a bright way, in an elegant way, targeted therapy, which are, of course, very important, and local treatments. Is it possible with stereotactic radiotherapy? We have some results. This was published 2 years ago from Germany in 106 patients with metastases, spinal and cerebral, combination with combined stereotactic radiosurgery. It seems to be achievable with quite a good survival rate, but I would be relatively cautious to do it outside of clinical studies. And you had the question this morning on how do we combine surgery and targeted therapy or anti-TKI or antibodies, and that's something which is not totally solved. But of course it's possible, but if you do so, do it in prospective studies. And at least in Europe, 2 prospective studies are starting on that. So at the end of my talk, I'm not sure I did convince you, I hope so. But you should know that most of the colleagues in different fields of radiosurgery and stereotactic radiotherapy are dead convinced on the impact. Just remind that the doses are not the same and everything is really dealing with the dose. So could we be curative? Could we locally control for a long term? For sure. But please, if you do so, don't wait for too long because, of course, there is a real volume issue. And please go to prospective studies for evaluating the role of combined targeted therapy and stereotactic radiotherapy. Thanks a lot.
I would like to start this presentation thanking the scientific committee for this kind invitation for the Saturn project on behalf of all the members of Saturn project. I am the coordinator of this Italian project together with Nicola Longo and Alchiede Simonato, and this is a multi-center retrospective national study including data coming from 16 referral Italian centers, and we included in this databases all the patients who underwent partial or radical nephrectomy for localized or advanced RCC in the period between 1995 and 2007. And we performed for all cases the follow-up in 2009, and at this moment we have the possibility to evaluate the results in more than 5,000 cases. In one of the first papers of this experience published in 2010 by my colleagues Giacomo Novara in the European Urology about the validation of the 2009 version of the TNM messaging system, we noted that histologic subtypes turned out to be an independent predictors of cancer-specific survival at multivariable analysis. And therefore, this observation supported our conviction and our idea that renal cell carcinomas are different types of tumors with different morphology, with different molecular characteristics, and at the same time with different cytogenetic findings. And this concept is always present and is considered also when we look at the different response of these tumor histotypes for medical therapy. And usually the most important guidelines like NCCN consider papillary RCC in the big folder of the no clear cell histology. But we must pay attention when we put together all the different tumor histotypes in the no clear cell folders, because as you can see in this slide, we have chromophobe RCC, papillary RCC, but also unclassified and Bellini tumor with prognosis significantly worse in comparison with papillary and chromophobe histological subtypes. And the same consideration were from this paper published in 2008 in the BJU International from Capitanio and co-workers. As you can see also in this experience, the survival of papillary RCC is in the middle between chromophobe and clear cell RCC. And again, when we look at the most important paper published in the literature in this field, we can observe that the percentages of the 5-year cancer-specific survival is in the middle between the worst prognosis represented by clear cell RCC and the best prognosis represented by chromophobe. But I ask you to pay attention to these differences in the 5-year cancer-specific survival between these two studies, one coming from Mayo Clinic after slight revision process, and another one that is a multi-institutional study from European centers in which we observed a 5-year cancer-specific survival significantly lower, but without slight revision of the cases. And this is an important message, because in these little studies published by myself in 2006, we demonstrated that for papillary RCC, the originally assigned cases, the cancer-specific survival is different in comparison with the cases assigned as papillary RCC after slight revision. And this is very important, above all, when we considered in the retrospective analysis cases observed and treated before 1997. And for this reason, we started with this study with a Saturn project, including cases observed and treated from 1997. And this is the publication in the BJU Urology about the prognostic factors in papillary RCC. Our task was to evaluate the prognostic factors in 577 cases observed in this multi-institutional experience. As you can see, looking at the characteristic of patient, we have a mean age of 62 years. The majority of these present showed asymptomatic disease, and we performed in 62% of cases radical nephrectomy, in 32 cases an elective nephron-sparing surgery, and in 6% of cases an imperative nephron-sparing surgery. But very important, when we look at the pathological characteristics of this tumor, we observed that 80% of the cases were localized tumors, and only in 10% of the cases we have patients with lymph node involvement or distant metastasis at presentation. And very important is that 30% of cases were grade 3 or 4 according to Fuhrman classification, and this patient can be considered as a type 2 according to the classification of the Lount and Ebel. And concerning oncological outcomes, in this experience, we have a median follow-up of 39 months with 464 patients alive and disease-free, with a median follow-up of 42 months. 40% of cases had a disease progression, 11% of cases died for the disease, and 5% of the cases died for other causes not correlated with the kidney cancer. Looking at the recurrence-free survival, we observed a 5-year recurrence-free survival of 85.5% of the cases, and the 10 years recurrence-free survival was 73% of the cases. And when we analyze our data according to univariable and multivariable analysis, we showed that pathological T-stage was not statistically significant at the multivariable analysis, and only lymph node involvement and presence of distant metastasis and nuclear grading turned out to be independent predictors of recurrence-free survival in this patient. This is a very important message, above all for the TNM classification, because I am convinced that the majority of the information coming from the literature are coming from clear cell RCC, and perhaps our TNM system works very well for clear cell RCC, but probably the situation for papillary, chromophobe, or other tumor histotypes is completely different, and therefore this could be considered in the future. Other very important message is grade 1 and grade 2. As you can see, the survival is significantly different in comparison with grade 3 and grade 4 cancer. But the most important prognostic factors are represented by lymph node involvement. As you can see, patients with lymph node involvement at the diagnosis showed a 5-year recurrence-free survival of 26.8% of the cases, and also the patient with distant metastasis showed a similar 5-year recurrence-free survival. What's about cancer-specific survival? This is the survival curves showing the 5 years and 10 years cancer-specific survival, and at the multivariable analysis we had the same results that I showed before for recurrence-free survival. Again, the only difference is that mode of presentation turned out to be an independent predictor of cancer-specific survival, and as you can see, incidental tumor showed cancer-specific survival significantly better in comparison with patients with local symptoms, or above all with patients with systematic symptoms. Of course, our study has some study limitation. The first one is that this is a retrospective analysis. At the same time, we included data coming from 16 centers. Then this is a multi-surgeon series. The specimen was evaluated by multiple pathologists without slide revision, and the treatment for disease recurrences was not standardized. And again, without slide review, it was not possible for us to assign correctly the subdivision of the papillary RCC in type 1 and type 2 according to the Lawent and Ibley classification. And it seems to be that this is important according to this paper published by UCLA, showing that type 1 tumor is significantly better in comparison with type 2. But I would like to ask you to pay attention when we use this subclassification between type 2 and type 1, because looking at the literature, this subtyping remains difficult, and different percentages of type 1 and type 2 are reported in the published series. This means that it is very difficult for the pathologist correctly assign the type 2 papillary, and then we need to have very experienced pathologists to have correct evaluation of this parameter. Another important point that it was not evaluated in the Saturn project was the role of nuclear grade. In this publication, some pathologists support the use of the nuclear grading instead of the Foreman grade for papillary RCC. And in this more recent paper coming from the UCLA, Clayt and co-workers showed that nuclear grading seems to be more predictive in comparison with the nuclear grading, as you can see looking at the different values of the concordance index. Another parameter that it was not evaluated because was available only in small percentages of our cases was coagulative necrosis. As you can see in the experience of the Mayo Clinic, coagulative necrosis for papillary RCC is not important. Vice versa, when we consider the experience of the UCLA necrosis turned out to be in papillary RCC an independent predictors of cancer-specific survival. Then in conclusion, I think that this data can demonstrate that papillary RCC is a low-risk tumor recurrence and cancer-related death after surgery. At the same time, we must pay more attention for patients with papillary RCC with lymph node involvement and presence of distant metastasis, and above all for patients with grade 3 and grade 4 nuclear grading according to Foreman. More attention we must pay for the correct allocation of the subtype and sub 1 and 2 in this category of tumors, and I think that to have more and more information and to better identify the characteristics of this tumor, we must consider in the next future more studies including molecular and cytogenetic prognostic factors. Thank you so much for your attention.